All right, good morning, everybody, and it's a pleasure to be here, and I want to thank the organizers for allowing us to discuss what has been a long journey. I'll have a little bit of a slide about that. So I'm presenting this on behalf of the co-authors that you see listed there, and you can see that it's an international study. At the end, you'll see there's really several dozen countries were involved in over 100 centers. So the Einstein-Jr. program, the adult program for Rivaroxaban development was called Einstein. So we call the pediatric one the Einstein-Jr. And this pediatric investigation plan was agreed upon between the European Medicines Agency and the FDA and the sponsor back in 2008. And I was just thinking about, putting that into some sort of context, at least for myself and maybe for the rest of you. So what happened in 2008? Amy Winehouse won 5 Grammy Awards. Some people probably don't even know who she is or don't remember her. The Dark Knight with Heath Ledger was one of the biggest movies of the year. The world financial crisis happened. Donald Trump supported Hillary Clinton in her bid to become president. That's true. President Obama was elected as president, and no one had ever heard of Brexit. So just to put into context how long it's taken to get to this point. So now turning more seriously, that VT in children is becoming a very significant problem, particularly in hospitalized children. The rate keeps climbing and climbing. There are several studies that have shown how much it keeps increasing year over year over year. And in our center, we see over 200 patients per year with thrombosis, something we hadn't seen before. This is mostly because we can do a lot better to take care of really sick, acutely ill and chronically ill children, mostly with the use of central venous catheters, which is a major cause of thrombosis in children. Now, anticoagulation options are limited. A lot of the drugs that are approved in adults are not licensed for children, nor do they have pediatric-friendly formulations. So we end up using these parental drugs that are been around for a long time, unfractionated heparin, enoxaparin, dalteparin, fondaparinux. These are all injectable drugs. The only oral agent that has been used significantly in children is warfarin, but it's very challenging to use. In fact, in adult medicine, I think they've gotten largely away from it in most situations. It only comes in tablets, lots of drug interactions, lab monitoring. It's very difficult to use and high risk for bleeding. There are no age-appropriate liquid formulations for oral agents available for children. Rivaroxaban has been licensed in adults now for many indications for quite a few years and has a great potential to be useful in children. So again, the pediatric investigation plan started in 2008 and was tiered. First, we did a physiologically based PK model. So that means a computer model essentially used information about metabolism in children to estimate what the dose would be in children, extrapolated from the dose in adults. So the idea was, let's get the same amount of Rivaroxaban in the blood, the pharmacokinetics in children, as we get in adults, because we think if we can do that, we can get the same great results in adults. But children are obviously not just smaller, but their metabolism is different. And I'll show you how that is, how that transpired in the following slides. Then an oral suspension was developed. Actually, it was challenging. We had one that didn't work so well, so we had to go back and make another one. But we developed an oral suspension that did work eventually. And then there was a phase 1 study to kind of confirm the dosing and look at some safety, a phase 2 study that further confirmed the dose and added some more safety. And what I'm going to talk about today is an analysis from the phase 3 study. And this is the design of the phase 3 study. It was open label. It was randomized with a 2-to-1 ratio of patients receiving Rivaroxaban to the comparator. And the comparator could be any of the drugs I mentioned earlier, the heparins, low molecular weight heparins, vitamin K antagonists, meaning warfarin. So we enrolled ultimately 500 children. That's no small feat in pediatrics for thrombosis. Even though the numbers are increasing, it's still not super common. And then patients would be on it for 3 months when we did an analysis, and then patients could stay on longer if the investigator felt they needed longer treatment. Just to show you, this is published already in the Lancet Hematology. This is the analysis just of efficacy and safety, which I'm not going to discuss because it's already published. I'm going to show you an analysis of the dosing and the exposure, which I'll get to momentarily. But just to show you one slide, here you can see Einstein is in the green. Einstein-Jr. is to focus on the blue line, and we're looking at recurrent VTE, one of the negative outcomes. And with Rivaroxaban, you can see it's about 1% as the cumulative incidence, and with the comparator, it was about 3%. Not too different. The point here is that Rivaroxaban at least wasn't worse. In fact, if anything, maybe a little bit better than the comparator. And if we look at bleeding, just focusing again on the blue line, which is the pediatric study, there's the bleeding rate about 2%, and very similar to the bleeding rate in the comparator. So not more bleeding, maybe a little bit better with recurrent VTE, but certainly not any worse. So the objective of this analysis was to determine the pharmacokinetic parameters of Rivaroxaban in children as it relates to dose and body weight. So one of the unique things about pediatrics is while in adults, probably the relatively smallest adults are about 50 kilograms, maybe a little bit less, and large adults could be as much as 200 kilograms, but typically maybe 150 kilograms, so about a threefold difference. I'm going to show you that in our study, we had patients who ranged a difference of 70, almost 70 in terms of their weight, 2 kilograms to almost 140 kilograms. So that's where in pediatrics things are very different than in adults who are generally speaking relatively the same size when you think about it proportionately that way. We'll look at the pharmacokinetic parameters as it relates to the outcomes, clot resolution, the most important efficacy outcome, bleeding events, the most important safety outcome, and then other adverse events. So here's the dosing. So first of all, I'll walk you through this. We had 3 different regimens. In adults, Rivaroxaban is, in the long term, given once a day. Initially, it's twice a day, but then eventually it's a once-a-day drug. In the older kids, or the bigger kids, 30 to 50 kilograms, well, let's start with more than 50 kilograms, they got the adult dose of 20 milligrams once a day. 30 to 50 milligrams, they got the adult dose, well, they got a similar dose to adults, 15 milligrams once a day. But as we got to younger children, we realized that the once a day actually wasn't working. And we determined that from the earlier studies where we saw that their trough levels were too low. So we had to change the frequency to twice a day. And something that we were not expecting actually wasn't found in the earlier model, that computer model we did, is that the youngest patients, those weighing less than 12 kilograms, so that's roughly a 1-year-old or less, needed dosing actually 3 times a day. That was a surprising finding. And all the work that was done led up to us figuring out that actually kids needed 3 times a day dosing. So here's some examples about how children are very different than adults when it comes to dosing drugs, and specifically here for Rivaroxaban. So let's look at the PK parameters by body weight. Let me orient you to this figure. Here you can see the dosing. So we see ODs once a day with a tablet, that's the black circles, twice a day, yellow circles with a tablet. And then we have the suspension 3 times a day in green, once a day in black, twice a day in yellow. So twice a day is yellow, once a day is black, with squares representing suspension and circles representing the tablets. And the idea here is essentially to have, the adult reference range you can see is in pink. So that pink rectangle is the adult reference range. And we're looking at 3 different pharmacokinetic parameters: area under the curve, which is the total exposure of the drug, and then the peak and the trough, the Cmax, the C trough, which is the peak and the trough. And the idea here is we want the dots to be inside that pink rectangle. And you can see for the most part that regardless of body weight, and you can see the body weight on the bottom going from 2 kilograms to almost 140 kilograms. That's what I was referring to earlier about all the different sizes of children. We want the dots inside those pink rectangles. And you can see the vast, vast majority of the dots, regardless of the formulation, tablet or liquid, and the frequency, once a day, twice a day, or 3 times a day, and the age, the weight of the patient, and as you could determine, obviously, different ages as well, almost all the dots were inside the pink rectangles, which is the adult exposure range, which is what we were aiming for. So we felt that we got the dosing eventually right. It took us those 2 rounds of testing to do that. What about relative to the outcome? So VT outcome, what we see here is the different outcomes. Normalized, meaning the clot completely resolved. That's the top one. Improved, obviously means improved, but not totally resolved. No change. And then the deteriorated and recurrent, you see very few dots there because most patients actually did very well and didn't have deterioration or recurrence. But the point here is that regardless of the formulation, in the patients that didn't do well, what we did not want to see was in these boxes a lot of dots, right? So in those boxes, it's that the level was too low. If the level is too low, maybe that's why these patients had their clot not improve or come back or deteriorate. But you see really only 1 dot for a very young child in there. So even in the patients that did not do well, it wasn't because we didn't get the dosing right. It was some other reason that couldn't really be determined specifically from the study. But you can't really blame the dosing or the drug because most of the patients, even those who didn't do well, had their levels where we want them. What about bleeding events? Same type of curve here. First of all, we didn't have a lot of bleeding events. Most of the patients you see, about 2/3 of them didn't bleed. But when we look at bleeding events in these boxes, what we don't want here is dots in these boxes. That is too high a dose. So did the patients who bleed have doses that were too high or levels that were too high in the blood? And you can see there is one dot there for genital bleeding, but otherwise, all the patients who bled still had their doses in the right range, and so they had bleeding for various other reasons, or just being on an anticoagulant alone is enough reasons to bleed. And so the issue here is that having an excessive amount of rivaroxaban in the blood was not the cause of the bleeding. And the adverse events, all the other adverse events looked similar. There was no difference there. So just to conclude then is treatment of children with body weight adjusted, so we're adjusting the dose by their weight, with these body weight adjusted rivaroxaban regimens resulted in exposures in the blood similar to those in adults receiving the typical dose of 20 milligrams once a day, which was the goal. And that the exposure, in other words, what they had in their blood, wasn't related to the lack of efficacy, bleeding, or adverse events. So those patients with poor outcomes, lack of efficacy, bleeding, et cetera, it wasn't because the drug was either too low in their blood or too high in their blood. It was for other reasons, and the dosing was still accurate and correct. And so based on this analysis, we conclude that body weight adjusted pediatric rivaroxaban regimens, either with tablets or suspensions, are validated, and this provides a new alternative for treating children with clots, a much easier one than those shots that kids have to get basically once or twice a day for months on end. That is no fun for parents to have to inject their kids day after day. They actually really hate it. So having an oral suspension or tablets that we can use would be a huge advantage. And the future goal is eventually to have this licensed all around the world for children and to have the child-friendly formulation available. So thank you all.